We want to welcome you again to our Adult Cardiac Surgery Database Quality Improvement Series on decreasing blood usage. On the call with me today from the STS, I have Emily Conrad, Leanne Jones, Paul Meehan, Banu Yatsi, and Melinda Offer. And then we have a speaker with us today. We have Dr. Karen Singh from the University of Virginia Medical Center in Charlottesville, Virginia. Dr. Singh is the leader of the Pre-Op Anemia Optimization Work Group, and she's going to talk with us today about optimizing preoperative anemia and decreasing blood usage. So welcome, Dr. Singh. Thank you so much
Thank
for
you.
joining
Can you hear me
us.
okay?
Yeah.
Okay, great. Should I just share my slides then? Share my
Yeah.
screen? Okay.
Yeah, sure. I'll stop sharing. Oops, here we go. We're just going to jump right in today.
Yeah, here we go. Okay, you can see that okay?
Yeah.
All right, so a little bit of background. Again, I'm a cardiothoracic anesthesiologist from UVA, and I was asked to talk about our experience at UVA with PBM, with patient blood management. And so this really does encompass preoperative anemia optimization, but also things that we do in the operating room and post-op to help with blood conservation and help with our blood transfusion rates. So really talking about all of those things. And so thank you for having me on. I know there's certainly centers that do an amazing job of this. Takes a lot of effort, and we're sort of in the baby steps here, but I think we made some good progress so far, and we're going to keep trying. So let me just figure that. Okay, there we go. Figure this out. Okay, so just a little bit of, putting everything into the picture here. So really, this all started with do cardiac surgery on Jehovah's Witness patients back in the 60s. And so being able to do something called like bloodless surgery in medicine, so it was really targeted towards Jehovah's Witness patients who could not receive blood products. But then it seemed like this was a really good thing for them, and it seemed to be helping in a lot of different ways to not transfuse. And so it was expanded to other patient populations and was often referred to as blood conservation. And now today, the more common title of what we call these efforts is patient blood management. And I'm just going to minimize this here. And in 2022, it came out with a sort of a global definition of PBM. I mean, there had been defined before, but this is really nicely showing what we might hear: a patient systematic evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. So it's really for the patients that we're doing this. We do like to make our transfusion rates look lower, but hopefully this is all for the benefit of the patient. So from our standpoint, in 2021, these newer updated guidelines came out from the STS, SCA, SABM to PBM for cardiac surgery patients. And so we wanted to take a closer look at these in our practice and make sure that we were following the latest guidelines. So we started to sit down and take a look at these. I'm not going to list all of these that we were following, but basically this is what we were doing, doing most of the major things here, hopefully doing them correctly. But there were quite a few things that we were not doing. We weren't using retrograde autologous priming whenever possible, which was a class 1 recommendation. While we had a pretty robust point of care viscoelastic testing with ROTEM used in the operating room, it really wasn't being used in the intensive care unit because of logistic reasons. So we weren't doing that. So while ANH was listed as a reasonable method to reduce bleeding and transfusion, we did not have any way or a program for ANH at our hospital. And then identifying patients preoperatively who are high risk for bleeding and performing everything possible for blood conservation for these patients. We weren't doing that really. And then we were not actually looking at anemia preoperatively, trying to see why patients were anemic and treating with IV iron if appropriate. And one of their highest recommendations is to have a multimodality PBM program led by a multidisciplinary team, and we did not have that in place. So our first step was really to build this multidisciplinary team. And so certainly I'm sure there are other people that would provide value for this team, but this was really our core, which helped get things going. So anesthesiologists, we had our lead perfusionists involved and some other perfusionists who were very interested in this. We did have a cardiac surgeon who helped us along as well. We had all of our APPs involved perioperatively and nurses. From hematology side, we had our hematologists and blood bank and also in anemia. And then, of course, we had Judy Smith, who also looked at our data and kind of was the glue that held us all together there. So this was our team initially. And our goals, what we decided we want to do is we wanted to increase our percentage of patients undergoing RAP. We wanted to identify and treat preoperative anemia. We did think it was important to increase the point of care coagulation testing in the intensive care unit. And then we were thinking about starting an ANH program as well. So a little bit about retrograde autologous priming, why even do it? Basically, you're just draining the patient's blood into the bypass circuit just prior to initiation of bypass. So you can limit the crystalloid priming volume, limiting hemodilution on bypass. It's, again, a class 1 recommendation on these guidelines. It's relatively safe and effective and decrease the risk of blood transfusion. And just before these guidelines were published, this meta-analysis was published as well, which showed that RAP was associated with significantly decreased RBC transfusion and no increased risks identified for AKI or stroke. So it seemed like something we should be doing. So we're not perfect at it still, but we've really tried to make an effort in having this happen in the operating room. So we started our efforts in late 2021, and you can see they've kind of increased over time, but it's been a slow increase. But one of the biggest things we focused on with this, it was just communication. Outside of one of our surgeons, everyone else was very happy to do the retrograde autologous priming, but as you're getting on bypass, it's a very busy time. And sometimes it felt like it wasn't the best time to communicate whether we're going to do wrapping or not. So we always do this during our timeout now. We discuss what is the starting hematocrit and discuss whether or not we're planning on wrapping. So that way, when it's time to go on bypass, there's no confusion and the perfusionists don't have to initiate a conversation or the anesthesiologists don't have to initiate a conversation as sort of a time when the surgeon's really just concentrating on cannulation. All right, so what about ANH? So this is basically you're taking the patient's blood in the operating room before you do any heparinization, 1 to 2 units typically, and you're replacing the volume if needed with some crystalloid volume typically. And then after you come off bypass, you return the blood to the patient after heparin reversal. It's listed as a class 2A recommendation as a reasonable method to reduce bleeding and transfusion. But it was mostly earlier studies that showed some benefit, and also with larger volumes of ANH seemed to show the most benefit. But so why not do it? It takes quite a lot of time to set up this sort of program, making up the protocol for it, educating people about it. Sometimes there's concern pulling blood off a patient, if they become hemodynamically unstable, what do you do then? And then there's always a risk of something happening with the blood that you took off, such as it clotting in the bag. And the other thing is, sometimes you may take off as enough blood that you become anemic on bypass and you have significant hemodilution of clotting factors. So there are some reasons why you might think twice before just starting a program right up. But we decided that this is something that we did want to do here. And so we created this protocol, created exclusion criteria. We had methods of, how to do this. And so we started our ANH program. We started in November 2022. We've had about 144 patients so far, so we're not doing ANH on a huge percentage of patients, but a fair amount. We did notice that slow blood collection seemed to be associated with the increased risk of clotting in the bag, and so we did work on that process and make sure that we're collecting the blood more quickly. And we were a site for the International RCT of ANH and cardiac surgery, so the results of that should be published hopefully in the next few months or something like that. So coming soon. All right, so that was ANH. I want to move on to viscoelastic testing. So this is very important. So we can provide point of care testing, indicating the need for, whether the patient needs platelets, FFP, fibrinogen, in a really timely manner. So usually turnaround time is 10 to 15 minutes. We were using a Rotem Delta system at that time, but it was getting old and we had to choose between continuing with Rotem with their Rotem Sigma, or going with a different platform. This was not working well for bleeding patients in our intensive care unit because it was performed down in the blood bank, it was far away. So it took too long to send a sample. It took too long to get the results back. The results weren't available in a timely manner. And so it just wasn't being done in the intensive care unit. So we did do a big analysis of that system before we spent a lot of money on something new. But we realized that really wasn't working. So what we were looking at is basically going with the Hemosonics Quantra, which is also a viscoelastic testing method that uses ultrasound to measure clot stiffness, versus sticking with the Rotem and going with the Rotem Sigma, which uses basically a rotating pin in a cup with blood to assess the properties of the clot formation, and you get this temogram similar to TEG. So we looked at these two systems in our intensive care unit, and we sent blood samples for both Quantra and Rotem, and we had pretty good correlation between the two. Quantra indicated platelet deficiency more frequently, which we will discuss later too. But it was pretty easy to use. We didn't have problems with cartridge failure. It was easy to read the display, so easy training for residents and APPs and other physicians. And so we decided for us the winner was Hemosonics Quantra, and so we went with that. And we started that in about January 2024. And so, of course, we had to make an algorithm, and just showing here just for an example of how we would do it, basically having different cutoffs for these parameters. And it tells us whether we have a fibrinogen deficiency and need to administer cryo, whether we may need platelets, whether we may need FFP. So very specific, helping us get target transfusion, and also assess after the patient has been reversed with protamine, whether or not we've done an adequate job of reversal, or we might need additional protamine to reverse heparin. All right, so this is just a chart looking at how our Quantra usage has gone up. The Q plus is what we're using here. And so you can see it's gone up over time. And one thing we noted over time when we plotted out our PCS cutoffs, which was less than 14 initially, it was correlating with a higher platelet count than what we really wanted. So we decided to decrease our PCS cutoff to less than 12 to just make sure we're not over transfusing platelets, which is the last thing the blood bank wants you to do. So anyway, so that we ended up just changing that recently, and we'll see how that goes. We also do a point of care platelet in the operating room to sort of correlate these. And they look at the platelet count in the ICU, certainly. And we don't want to transfuse anyone who's not bleeding. This is just for bleeding patients. So looking at our kind of trends and post-operative transfusion, this is in the ICU. We did see a decrease in FFP about after we started the Quantra. But, you know, our cryo went up, which is probably appropriate. Our platelets went up as well, too. So again, we'll see how that plays out with our decreased PCS cutoff that we just changed to. And then we also looked at when we started Quantra, after that year, we had a great year for reops for bleed. But then in 2025, I'm now told that we have several, and so that's another issue. So I think there's only so much that this point of care testing can do. If there's actual surgical bleeding happening, it may help with targeted transfusion, but the patient likely is still going to have to come back to the operating room to fix it. All right, so now for moving on to preoperative anemia. This was probably one of the most challenging areas to work in because there's so many moving parts. But I just wanted to review that there are some great guidelines out here looking at how do we approach these patients for cardiac surgery, how do we screen them, test them. They obviously recommend screening everyone for anemia and for iron deficiency, even if patients that don't have anemia, screening for iron deficiency and treating. Recommending that. And there's some recommendations regarding EPO here as well. So anyway, I just wanted to highlight that a lot of these guidelines are out there that are very helpful when you're getting your program going or deciding how you're going to make it work. And this is just a nice slide from that document as well, just showing that a lot of patients are anemic. They are much more likely to be transfused, and treating with iron can be helpful and decrease the risk of transfusion. And that was true when we look at our patient population. We found that about over time, we've seen like 30 to 40% of our patients present with anemia, which we define as hemoglobin less than 13. We defined all comers as less than 13, although the WHO definition is less than 12 for women. But we found that women have such a higher rate of transfusion. We just decided to keep it the same, less than 13 for men and women, as they're doing in some studies when they're looking at these. So, and anemic patients are much more likely to have a RBC transfusion here at UVA too, when we took a look at that. So with the help of our hematologists, we created an algorithm for patients to be assessed for anemia beforehand, to be treated with iron. One thing that we're not doing now, we're not assessing everyone for iron deficiency and treating everyone. That may be something down the line, but right now we're just trying to get patients who are anemic with iron deficiency treated with IV iron if possible before surgery in a timely manner. We're going with IV iron more than PO just because of the time sensitivity, that there's not much time between when we see the patient and they're coming for surgery. So it's typically treated with a single dose of IV iron. This is just an example of what our workflow for the outpatients. And basically we had some reflex iron studies ordered, and then somebody looks at them and then talks to the patient, orders IV iron if indicated, updates the PCP. And this is just looking again at, we're still missing some patients, but we're doing a lot better job than what we were doing beforehand, where we were really not getting anyone iron studies who were anemic, and now we're about up to 70%, and we're trying to get it even higher. But again, with staffing challenges and time constraints, it is somewhat challenging sometimes to do that. And so we talked about doing the outpatients, and we kind of got that workflow going. And then we're like, well, we need to look at the inpatients. Should we try to treat them with IV iron beforehand? And I mean, it is recommended to do that. And most of our patients who are anemic are urgent patients or in the hospital first. And they're usually in the hospital for about 6 days beforehand, before surgery. So there's definitely time to give them IV iron if indicated. So we created a smart phrase and the H&P and for cardiac surgery and trying to get that ordered beforehand. But we are still working on this process because just because of variability in providers, we're having some difficulty in catching all these patients for sure. So just a quick slide. I don't want to bore anybody with a bunch of slides from UVA, but just to kind of how we're doing now. This is just over time, our blood transfusion or any intra blood transfusion or cabbage, and then it's the 2024 STS average here. So, we are doing better than we were in the past for sure, but it's something that we have to constantly be vigilant about. And sometimes it's like 2 steps forward and 1 step back. And so we constantly are reviewing data, trying to see if there's room for improvement. Is there anything that we're doing in the operating room that's different? Anything the surgeons could be doing. So just trying to keep on top of everything. This is post-op product as well. So just keeping an eye on that too. So I would say our successes are that we did increase the percentage of patients undergoing RAP. We were able to start an ANH program for cardiac surgery. We're working on the anemia portion as hard as we can, but it's a process. And we were able to do the point of care coagulation testing in the ICU. But it's just probably just like anywhere, there's challenges with institutional support sometimes, staffing and bandwidth. Just for ANH, sometimes we think maybe we'd like to do it, but we have to supervise another room, and we can't be there to make sure the ANH is done safely. So sometimes we can't do that. I know we're trying to catch as many anemic patients as we can, but again, the nurses get very busy in the clinic and on the ward, and so that sometimes they just get missed. But again, something that we're working on. And I just did want to highlight recently in 2025, there was a document, an expert consensus document, cardiac surgical bleeding transfusion quality metrics. So some recommendations, and I think it's a really nice overview of what we should be doing about bleeding and cardiac surgery. And especially I think that we're going to be looking more at this portion here, looking at factor 7 was frequently or sometimes used for cases of extreme bleeding. And then now we have PCCs, 4-factor PCCs, that have shown to be probably more effective at reducing transfusions and have a better safety profile. So this is something that we'll be looking at PCC over FFP possibly, and more for our bleeding patients. And so be looking at that in the future. And I think that's all I have. So I wanted to leave some time for questions. And I wanted to thank all these people on the slide for all the help that they've given me in helping keep this PBM group going and continuing to evaluate it and move to whatever is next. Thanks.
Thank you so much, Dr. Singh. That was wonderful. We appreciate you coming today to speak with our group. Everyone, the Q&A box is open if you have questions for Dr. Singh. So far, we just have one question about copies of the slide deck. We usually post our slides after the webinars, so
Yeah, I mean, I don't think that would be a problem at all. I just have to make sure I know I put some UVA specific data on here, but I don't have any problem sharing that at all.
All right, perfect. Thank you. I have just, well, maybe a couple questions. So could you explain the benefits of RAP?
Sure. So really the goal is to minimize the pump prime. The pump prime is basically the amount of volume that has to be in the pump to safely go on bypass, so you have enough reserve volume, so you're not, getting air in the pump and things like that. And so there has to be a certain amount of pump prime. It's typically crystalloid, but with the retrograde autologous priming, you can actually, before going on bypass, use some of the patient's own blood to help form that necessary volume of pump prime and get rid of some of that crystalloid. So it will decrease your overall crystalloid pump prime that you need. And then when you go on bypass, you would have a lower hematocrit, nadir hematocrit, hopefully, going on, because you're not just hemodiluting everything as much. Other things that are done typically, so I think our bypass circuits are much more but much better than they used to be. For example, and the surgeons are really cognizant of this as well, though often, instead of having a really long tubing for the venous return, they might cut it as short as reasonable, so you have less crystalloid going back in the pump with that. Or they might even prime with the venous line going back in the pump and not have crystalloid prime in there, but just prime with the venous return blood. So it's it's just one of kind of many ways we're trying to minimize that crystalloid pump prime to minimize hemodilution.
Thank you. And would that be the same concept as ANH too? Or
well, with ANH, the goal would be more that you are preserving the patient's clotting factors and platelets so that they never have to get go through the bypass machine and get sucked out and self-saver and things like that. So basically with ANH, you're trying to pull off the patient's blood beforehand and kind of protect it from all of that, so that you can just give it back when you're coming out, after you've come off bypass and after you've reversed with protamine, and hopefully you're giving back clotting factors that are working, platelets that are working, as well as the actual red blood cells. So I would say they have two different reasons for existing, but they're both the goal for the same is just decreasing bleeding.
So, and Jill is asking, do you routinely do ANH at UVA?
I wouldn't call it routinely. I will say that we used, when we were forming our protocol, we looked at a lot of other people's protocols. We kind of wanted to not do anything crazy, not do anything that was really out of the box. And so we looked at other centers like Hopkins, Mayo Clinic, and things like that, and tried to, read best practices that had been published and tried to stick with that. And so There's a lot of patients that we often do surgery on that would meet our exclusion criteria, like severe AS patients or severe mitral stenosis patients, patients with left main disease, unstable patients coming in, LVAD patients, that sort of thing. So we're likely not going to be we're not going to be performing ANH on those patients. And that's a big percentage of our patients. When we do get a patient who's a great candidate for ANH, they have the volume and they're relatively hemodynamically stable. We do want to perform that. And I think I mentioned earlier that our biggest limitation is probably just staff availability. And so if we have the bandwidth to do it, when we can, we will. So I wouldn't call it routine here at UVA. I know a lot of places probably do it much more routinely. And they do have, some other places, they have some great resources too, like people helping get the blood off and fellows watching the patient and that sort of thing that we don't have now. So I think we're kind of going to keep reassessing how it's going, and we're constantly trying to do what we can to make it more feasible now from a staffing standpoint. So yeah, I wouldn't call it routine, but I think we would like to do it more than what we do now.
Thank you. So I guess a common theme amongst all of the speakers that we've had talking about decreasing blood usage is the fact that it takes many hands to make this work. The whole blood conservation concept takes many, many people. So, and we see that you at UVA have, you highlighted your multidisciplinary team, and that has been a pretty common theme across all the centers that we've heard from. Can you talk a little bit about your IV iron? Do you have a dedicated infusion center where that's given, or what kind of resources are you using for that?
Yeah, there are a couple of dedicated transfusion centers that if patients are coming, for electively for surgery and they've got time to go beforehand, they try to get them scheduled into those. And I think initially the process was more difficult, but then it's been kind of streamlined and has gotten easier over time. So I think that's working pretty well. Most patients who have indication for IV iron and they're able to set that up, get their iron. And for inpatients, it is actually easier because the patient is already here. And so basically all that needs to happen is a order needs to be placed for the iron. And so that should be easier. And again, one of the struggles that we have is on our cardiology floor where patients typically are before surgery. There's like different residents rotating through there all the time. And so it's just the consistency of having someone making sure that we're looking at the labs, we're getting the iron studies when indicated, and they're getting the iron. So we're trying to streamline that more and get more resources to make sure that we're looking at all those patients. But yeah, it takes a big team and a lot of people working in their own sphere of influence to accomplish anything, I think for sure. So we have been lucky in having a lot of people that are motivated they want to improve patient care. They want to, do this to make the patient's experience better, decrease transfusion. And it's just a matter of kind of harnessing that and making it work within whatever system that we have.
Gotcha. So intraoperatively, do you have is there a target hemoglobin level or hematocrit? How low are you guys letting patients go before you transfuse?
That's a good question. So typically patients are the lowest when they're on bypass. Usually that's when they're the lowest, and that's the time they get transfused, unless you have massive, like a great amount of bleeding after bypass, because usually at that point we have self-saver or ANH blood or whatever that we can give them. So usually the question comes up when they're on bypass, so they're hemodiluted, and then we need to think about transfusion. First, we'll assess the volume that the perfusionist has, and if they can hemoconcentrate, we'll consider hemoconcentrating to increase the hematocrit that way first before just giving them a Paxil. So I would say on average, we're going between a crit of 21 and 23 before we'll pull the transfusion trigger. But we use it in context, we use the DO2 as well. They have luckily, it can be calculated automatically with the perfusionist machines that they have. So we targeted DO2 of 280, just based on some previous studies that have come out showing maybe better renal or less AKI afterwards and targeting about 280. And so that's our target. And so if we're on the fence about transfusion, we're going to consider, well, what is the DO2? As long as we want to make sure our flows are optimized first, because that's going to influence the DO2. If our flows are optimized and the DO2 is really low and the patient is going to need volume 2, then we're going to likely transfuse with Paxil. Does that make sense?
Yep,
Yeah.
that makes sense. What is your normal prime volume?
So the last time I checked with our perfusionist, Mike, it's just less than a liter, I believe. I think they're like 900 or something like that.
Okay. Do you have, you may have touched on this earlier, but is your approach different when treating Jehovah's Witness patients?
It's a great question. So there are some centers that are totally expert in treating Jehovah's Witness patients, like Hopkins, and they have clinics and pre-op clinics, that are just especially to treat those patients. We do treat Jehovah's Witness patients at UVA. It is surgeon specific whether or not they want to do surgery on those patients. But I think that's an area where we could definitely work on. Those patients are likely to be getting EPO beforehand. I would say that's the big difference between those patients and other patients presenting is they're more likely to get EPO and iron and everything beforehand, get a hematology consult, just get a little more attention beforehand, making sure that we're optimizing red cell mass before surgery. And then when we have a specific blood consent that we can go over with the patient so they can decide what components of blood they may accept afterwards, possibly if not accepting whole blood type transfusion, but whether they might accept PCC or fibrinogen concentrate or that sort of thing. So we have a specific blood consent for those patients, which I think can be really useful. And then intraoperatively, it's always amazing to me sometimes how little blood we can lose in cardiac surgery sometimes. So just very meticulous surgical technique is used, obviously, to help with that. Yeah.
And so you mentioned EPO. Is that something that's reserved just for the Jehovah's Witness cases, or do you ever give that to other patients?
That's, typically just for Jehovah's Witness patients. And I know that the recommendations now are definitely shifting towards using EPO for all anemic patients. It's not, it's not like a class 1 recommendation now, but it's been demonstrated to be fairly safe. I think the question it comes down to is basically cost. So getting it covered, getting insurance to cover it. We've talked about this with our hematologists and whether or not we should be including EPO in our algorithm. And they're sort of like, no, let's just do the iron. Let's not even try to do the EPO. It's just a huge battle with insurance from their standpoint, I guess. But maybe that will change over time. I think it's all, we just have to look at costs and resources when we're looking at all these things. And I don't think yet it's definitely shown to have a big, a clinical benefit down the line. But that may change. And so I think that it's good to just keep an open mind and keep looking at studies coming out and seeing what they show. But I think definitely some centers are using it pre-op all the time, and then others choose not to. And I guess we're just still on the not to side.
It's definitely a balance, cost versus benefit for sure. Don't see any more questions coming in. Oh, here we go. Jill is asking, it seems like RAP may be most beneficial for smaller body size patients. Is that true?
Well, I think that you have less red cell mass likely if somebody is smaller. And so anything you can do to decrease that pump prime may make a bigger impact in those patients. So I definitely think, yeah, they may benefit more. But in the studies they've done on these, it's really everybody can benefit from RAP. Even patients with like a higher starting hematocrit will benefit from a standpoint of having post-op transfusion from RAP versus not RAP. So we tend to RAP all comers. So whether they're big, small, have a high crit, have a low crit starting, it can help everybody. So we try to treat everybody the same, unless they're like terribly hemodynamically unstable. We try to do the RAP. But that's a good point. If a patient is very small, often, and female patients are often smaller, but they have a higher rate of transfusion during cardiac surgery, even if they're not anemic. So these patients definitely benefit from anything that we can do to decrease hemodilution. Yeah.
I have another question around perfusion. So do you routinely hemoconcentrate on pump or just when there's a low hematocrit?
I wish my perfusionist was on here, but from my experience, if they have a huge large volume in the reservoir, then often they're going to hemoconcentrate, unless the hemoglobin is, or hematocrit is already very on the high side. They're likely going to hemoconcentrate. If it's anywhere in the middle or if it's low, yes, hemoconcentrate if they have that volume to hemoconcentrate. It's really for patients with, I would say, a lot of volume. So you've got your like chronic aortic regurgitation patients, chronic MR patients, heart failure patients sometimes. So if they have a lot of volume, their crit is medium to low, they're going to, hemoconcentrate those patients. And then for the rest, probably we're just going to look at it more if we're trying to boost their hematocrit and they can hemoconcentrate. If they have enough volume to hemoconcentrate, consider doing those patients as well. So I wouldn't say it's routine, but it's used frequently when we have the volume. Yeah.
All right, so Michael is on. Michael, did you want to add anything?
Yeah, I was just gonna say about the hemoconcentration. Karen's right. We don't do it frequently, and it's become a little less frequent lately because of the way we're starting to think about AKI in the units and making sure that patients are properly fluid resuscitated going from the OR to the unit. So some of our surgeons are a bit worried of us taking off too much volume. So we have a pretty good line of communication for them, asking if we can take volume off if we have a lot of extra volume, or and if we do, giving them frequent updates about the amount that we've taken off too, just to, keep an eye on fluid balance afterwards and making sure that the ICU isn't having trouble keeping up with volume resuscitation because we've dried them out too much in the OR.
And Mike, as part of that, you want to touch on, because it also depends on the cardioplegia approach as well, right?
It does. So when we're using crystalloid cardioplegias, the two most common I think of are del nido cardioplegia or custodial cardioplegia. You can give anywhere between 1,000 milliliters to 2,000 milliliters, depending on the type to your patient, and that is significantly hemodilutive. So we will use hemoconcentrators to take that volume off to get to get the patient back to net neutral. And when I mean net neutral, it's their blood volume plus whatever volume was in the bypass machine. But we do use those hemoconcentrators to get off that extra cardioplegia for sure. Because someone who gets a liter and their blood volume is only 4 liters to begin with, that's a pretty big hit if we don't take care of that.
Thank you. Thanks so much. If anyone else has any questions, just put them in the Q&A. Can stay on for a little longer if you want. Doesn't look like we have any questions coming in. This was an excellent presentation. We thank you so much for sharing your knowledge with us. Jill says it was very interesting, and thank you so much to the UVA team. Yes.
Thank you. Thanks for having me. I really appreciate the opportunity to talk about it. So thank you.
Yeah, it's great to share ideas across sites. It just makes caring for our patients even better. So
Right.
across the board. So we really appreciate you coming today to share with us.
Thank you.
Let's see. I just have, let's see, our next quality improvement series call is on May 21st. We do not have a speaker for that call, but we would love to hear from you. If you have a project that you're working on, like the one at UVA, or anything you want to share related to decreasing blood usage, please reach out to me, Nancy Honeycutt, or you can reach out to Carol, or me or Carol is fine. Here's our contact information. And then monthly webinar is May 7th. And still no more questions. So I guess we can close for today. Thank you again, Dr. Singh, for sharing. And thanks everyone for joining. We'll see you on our next webinar on May the 7th.